All right, hey guys, welcome to the replay. For those of you who are looking to watch this live, I'm going online to share it now, so give me just a second. Let me get this set up. We're going to be talking specifically about some scenarios published by CMS to understand how and when, why to use the ABN. Now, I'm not going to get into more information because this is a full module. Like, I teach a 30 to 60 minute full module on using the ABN in my Medicare course. But what I'm trying to do here is really just answer a question. Let me find this so I can share it. All right, here we go. I'm in here. Let me get this out real quick. I'm going to put this out into the Medicare group and on my personal profile. When and why ABN. Guys, if you join me in YouTube, post your questions in the YouTube chat. I'm going to be following along. If you are watching this through Facebook and you're not logged into YouTube, I'm not going to be able to see your messages, so I'll go back and find your questions later. But find my YouTube channel, subscribe to the YouTube channel. As you post questions there, I'm able to respond. And you guys know it, my goal is to grow that YouTube channel to 1,000 subscribers, 4,000 watch hours. That channel helps me produce more content. Your questions give me better ideas for the content you guys are looking for. Okay, so here we go. Let's take a look at this. I'm going to go Andrea's question specifically. And Andrea, I hope you don't mind me sharing your question. But Andrea's question specifically was related to somebody else's question, which was, can I ask if anyone's doing prehab evaluation for pre-mastectomy, lumpectomy? What code do you use for billing? Does Medicare cover the evaluation? What is your process? And that's what I'm going to go through. I'm going to answer that question. Now, to Andrea's post, she was asking basically the same thing. Pre-surgical, especially when baseline measurements can help with identifying onset of lymphedema sooner. And then she's saying, is this a covered service or would it be non-covered as preventative? Or is this a third blue ocean? For those of you guys who don't know what a blue ocean is, it is identifying areas of opportunity. So I would say classic physical therapy is what we would call a red ocean. Lots of competition, lots of providers, everybody like cutting costs, cutting reimbursement, cutting deeper to become, the lowest cost provider, especially in third-party payer systems. It's just a red, bloody ocean nobody wants to be a part of. Nobody's going to be successful there, at least none of us. So what we're looking for is a blue ocean. A blue ocean is lots of opportunity. Nobody else is there. Lots of people need your help in these areas. I think lymphedema is huge, especially in the private sector, outside hospital settings. I think there's such a massive opportunity there simply because people don't even know they're dealing with issues related to lymphedema. They just think that, they're gaining weight, not realizing it's fluid and not realizing the impact it has on overall health. So lymphedema itself, blue ocean. Within lymphedema, these pre-surgical evaluations would be huge opportunities, once again, if nothing else, to get the baseline data and information, show the Medicare beneficiary some things that they can do pre-surgical, post-surgical. Just, I can't even go on more, but let's get into the specifics. So if we look at, let's go to a classic, CMS Chapter 15, and we're going to jump down real quick to medical necessity in Section 220. I think this is just so important when you're looking at, what's reasonable and necessary. And of course, they outline all this here, but I'm going to go into this section under rehabilitative care. Talking about requiring the skills of a therapist. Anytime you're getting into a situation of an evaluation, establishing goals, designing a plan, instruction to establish compensatory skills, selection of a device or augmented function, training family, friends. These are all absolutely covered services. This is one of the biggest barriers somebody who's not contracted with Medicare is the evaluation is almost always a covered service. Unless the beneficiary is coming to you specifically for a golf performance evaluation, specifically for weight loss evaluation, not related to medical issues. In 90 plus, and I can't say that, in most of the situations, if you're a clinician and a person is seeking an evaluation from you, it is a covered service. And so to go to Andrea's question, yeah, I would say always this is a covered service, especially if they're looking at a scheduled or planned procedure like that. That being said, how do you determine diagnosis, medical diagnosis, treatment diagnosis? You use your best judgment. You know, you're going to be kind of floating through this gray area, trying to find the most appropriate. What are they having the biggest issues with? What are the biggest complications? It might be a pain-related diagnosis, pain in an extremity or something like that. It might be a function-related diagnosis. You're just going to do your best to pick the closest, most appropriate diagnosis. And then in terms of treatment, now, I don't know anything about what you guys do, so it's hard for me to say what codes you would be billing. But I can tell you from my perspective, if somebody came to me pre-surgical and was looking for something like this, there'd be a component of education. Now, we don't have a CPT code for education, but if the education's on what kind of exercises could be done pre-surgery, post-surgery, then it would be a 97110. If we discuss, positioning and energy conservation and functional activity stuff from an educational perspective, I'm probably going to bill something like 97530. If we actually do exercises and manual therapy, it's going to be 97140. There's always going to be kind of those codes that it's based on the intent of the treatment. And based on what's actually being provided, you're going to choose the most appropriate code based on the number of minutes, and you're looking for the most minutes, right? For whatever topic you're doing. So, topic of this video is not coding, it's ABN. So, first question is, I would say the evaluation is pretty much always a covered service in that whole first session. Then based on your findings, if this person's like super high level, just doing amazing, no cognitive deficits, no difficulty with retention, you can teach them what to do and they can retain it, understand it, now they just need to do it, then the follow-up sessions would most likely not be covered, not be medically necessary. And so let's look at CMS Medicare Claims Processing Manual, Chapter 30. This is where we're going to go down to Section 50 for information on utilizing an ABN. And I'm going to specifically come down to ABN Scope 50.3 because there's a mandatory ABN and there's a voluntary ABN. The voluntary ABN, we're not going to get into it here, but voluntary ABN would be utilized when you're providing services that are never, there's a specific term Nancy likes to use, and I try to follow her guidance. It's these services statutorily excluded. You can look that up. There's a great handout on it. I'm not going to get into that, but that's when you use the voluntary. The mandatory would be specifically, let me zoom in so you guys can see what I'm looking at. Mandatory use when a service is not reasonable and necessary. That's probably the number one factor. So physical therapy, occupational therapy, speech maybe would otherwise be covered normally, but in this case, it's not reasonable and necessary. The other one that I usually go to when outpatient therapy services are in excess of the therapy cap. Now, we don't usually use the term cap anymore. We use the term financial threshold, and they don't qualify for exceptions. So those are probably the two most common scenarios. Guys, get in here, look at these other scenarios for a mandatory ABN. But now, let's get into some of the cool stuff. Let's look at Medicare's specific triggering events and their examples for when you would use an ABN. So that takes you to section 50.5. And I think this one kind of goes to Andrea's primary question. Would it be a covered service? Would it be non-covered? Would it be preventative? I'm just going to read this and then we'll discuss it. So at the initiation. So an initiation is the beginning of a new patient encounter, start of a plan of care or treatment. If a notifier believes that certain otherwise covered services or items would not be covered, not reasonable and necessary at initiation, an ABN must be issued prior to the beneficiaries receiving the non-covered service. So they give you a great example. Mrs. S asks her physician for an EKG because her sister was recently diagnosed with AFib. Now I'm going to apply this to your example, Andrea. Mrs. S has no diagnosis that warrants medical necessity of the EKG, but insists on having an EKG even if she has to pay out of pocket for it. The physician's office issues the ABN prior to the EKG being done. So what would that look like in this scenario? If the patient is already diagnosed, if the patient is already having a procedure planned in the future, the evaluation plan of care goals, all of that is absolutely indicated and is a covered service. I would say if there was a scenario where the patient came to you and said, I have no medical history of any kind of complication, but I want to know because my mother, my sister, my aunt, my whomever has been diagnosed. I want you as a therapist to evaluate me, determine if I have any kind of lymphedema or any kind of problems, and if I did, what would I do? That would be more in the world of preventative. That would be more, they don't have a physician referral, they don't have any medical history or any indication that there's some medical complexity going on here. They're literally just coming to you to kind of get a baseline. Maybe in 10 years, they want to have something to reference back to say, this is where I was, and now these are the changes that I'm seeing. In that situation, we might be looking at something like this, where it's not a covered service. I can't imagine that being the situation, but it would be a non-covered service. You'd have an ABN signed. The patient would choose one of the three options. When we're talking about options, I'm going to save that for the course. You can find the information on option A, B, and C. But in that situation, it's not covered. You would have an ABN signed and the patient would pay out of pocket for that service. But in the scenario brought up on Facebook, the patient has and is planning a procedure. I'd say it's absolutely indicated. The situation on Facebook more likely falls into Section B. Section B, a reduction occurs when there's a decrease in a component of care, frequency or duration. The ABN is not issued every time an item or service is reduced, but if a reduction occurs and the beneficiary wants to receive care that's no longer medically necessary, ABN must be issued prior to delivery. Somebody's reaching out to me, sorry. Okay, so Mr. T, I love Mr. T, is receiving outpatient therapy 5 days a week, and after meeting several goals, therapy is reduced. Now, guys, if you know Fitz in our group, he uses this model very effectively. I would love it if he wants to share a Facebook Live on the topic because he's doing a great job with it. So Mr. T wants to continue to receive, he's achieve a higher level of proficiency in performing goals related to activities, wants to continue to receive therapy 5 days a week. He's willing to take the financial responsibility for the cost of 2 days of therapy per week that are no longer reasonable and necessary. In this case, an ABN is issued. So in your example, Andrea, I would say that the eval, the plan, the first treatment, all covered. Maybe a second follow-up treatment still covered to review and ensure the patient fully understands what needs to be done. But then if the patient wants to continue working with you, just to make sure that they're doing things right and have the reassurance that a therapist is watching and, have you accessible. But it's not really medically necessary at that point because they've shown that they can do what you recommend they do. But you also know that you're going to be treating them post-operatively. An ABN would be a great opportunity, so maybe you reduce their covered service to 1 session a month for reassessment. And if you look back here, continued assessment and analysis during implementation of the service at regular intervals. That could be a once a month deal. And then they could pay you out of pocket 2 times a week to come in, make sure they're doing everything right, all that stuff. And then the last scenario that Medicare publishes is at the termination or discontinuation of certain services. The ABN is only issued at termination if the beneficiary wants to continue receiving care. Now, this is a very common situation. I think most of us have understood continuity. Most of us have understood for over a decade. Patient finishes formal therapy. They start a wellness program, self-pay. I think a lot of us haven't been appropriately using the ABN in that situation because we've been thinking of it more as a voluntary situation, right? Like personal training is never a covered service. But certainly I think this brings to light use of the ABN appropriately. So their example, Mrs. X has been receiving covered outpatient speech therapy, which could be OT, could be PT, has met goals, has been given exercises to do at home, does not require the therapist intervention. Mrs. X wants her therapist to continue to work with her, even though continued therapy is not medically necessary or reasonable. Mrs. X is issued an ABN prior to speech therapist resuming. That is no longer considered medically reasonable and necessary. So, classic scenario. Your patient loves you. Your patient appreciates you, wants to continue to work with you. You understand from your professional judgment, the services do not require the skills of a therapist any longer. This individual will be safe to work with an assistant without your direct supervision. They'd be safe to work with an LMT, an ATC, and other non-covered provider, non-contracted provider. You've taught them everything. You've provided all the services you need. Maybe, there would be room for an assessment down the road if it's a progressive condition that's not expected to resolve back to premorbid status. But that being said, the patient, the beneficiary, is free to hire you to continue to provide what's now become a non-covered service. In that case, you issue the ABN. You choose the appropriate option between A, B, and C, and now the patient is free to pay you out of pocket. You do not have to maintain the Medicare fee schedule. You can charge your cash rate, which in most cases is higher than the Medicare fee schedule. If you determine, quarterly, you're going to do a covered reassessment progress note, not a reevaluation, a reassessment progress report. Look at the original plan of care. Look at what you were doing in terms of progressing and goals and progress. That would be a covered service. That could be a visit that is submitted on a claim to Medicare that the progress report probably is going to be outside the certification period. So you would have to send that to the supervising physician, the referring physician, I shouldn't say supervising, the referring physician to get certified so that it may be submitted. But the sessions between those progress reports are not covered. Those are the ones that would be self-pay services. So guys, I hope this sheds some light on utilization of the ABN, on CMS guidelines, where to find the information, go to the source. In the Medicare billing course, we dive a little deeper. We pull up a sample ABN. I show you exactly how it's completed, what goes in what field. There's instructions for that. Certainly you guys can figure it out on your own. It's just a little easier when somebody is showing you who's been doing it for a while. But if you have any questions, any other concerns, any ideas on this topic, back to blue ocean opportunities. For decades, we've understood patient finishes formal therapy, they go to a wellness continuity program. But I haven't seen enough people implementing a concurrent self-pay services along with covered services and doing it properly, doing it with the proper documentation, forms, procedures, the risk analysis that Nancy always talks about. So guys, if you're going to do it, let's do it right. The resources are here. I know it's a little bit daunting at first, but once you get into it, you realize it's not as complicated as it seems when you have the information that you need. All right, I'm going to wrap this one up. Thank you again, as always. Take a minute, subscribe to the YouTube channel. Help me grow that channel so we can bring more resources out to this community. Guys, I'll see you later today, probably.